Okay, I will start as usual on the Rehab Adda. Mm. Today we will be discussing about the knee X-ray made simple from basics to clinical application. As usual, we will try to finish this class by the time you finish your tea, and that will be our main target. So let's start this session. Please. So welcome from Bangalore Airport. So knee X-ray, what it is used for, mainly bones, joint spaces, alignment, signs of injury or disease. It does not directly show ligaments or cartilage, but gives indirect clues. Why it is important? Because most of the time, whenever we order any X-ray, the moment we order X-ray, the only thing that is in our mind is we have to look for the bones. But if you evaluate the X-ray minutely, there are multiple things which will decide whether you have to undergo or plan for further evaluation, including the MRI or ultrasound or anything else. So knee X-ray is a very important component to decide about any uh, issues around the knee. Now, what type of X-ray should be there, what shall be done or not to be done. So there are three types of X-rays which is very commonly used, and these X-rays are mainly AP view. In AP view, there are two types of X-ray. One is supine lying and one is weight bearing or standing. And then the lateral view, and then the skyline, or which is also called patellar view. Mainly the skyline view is mainly for this understanding if there is any fracture or any pathology in the patella. Now, X-ray knee, what is the important things that you have to know? First and foremost and most important thing is how much femur. This is the femur. All of us know. This is the tibia. This is the fibula. So how much of the femur has to be covered? How much of the tibia and fibula should be there whenever we are taking an X-ray or whenever we are looking for it? Ideally, it is one third of the femur and the one third of the tibia has to be covered. Whenever we are seeing, we have to look into the another important thing is, especially in the AP view, for the alignment. Alignment is an important component. What is the alignment of the joint is proper or not? For the alignment purpose, you have to look into this app. This my cursor is visible, okay, to all. So this is an important thing. That is the patella that will decide whether it is aligned properly or not. If it is in the midline or middle of it, then it is more or less properly aligned. Or if it is laterally, it is aligned to, suppose this patella shifts to this side, then it is quite possible it may indicate there is some pathology higher up, that is around the hip, that may be externally rotated. That may be internally rotated, and if it is externally rotated. Now, whether this is a right knee or a left knee, how to find it is mainly the MBBS thing. It is the fibula. Okay. So this is the fibula. La is in the last word is the lateral part. So this is the lateral part. So this is the patella. Then here you will find the epicondyle. This is the medial condyle. This is the lateral condyle. This is the tibia, interarticular sets. Now this is an important part. This is the fibula or the fibula. Why it is important? Because this is the area, this neck area, that is very important, because this is where the fibular nerve or the common peroneal nerve is all around. And if there is any fracture or any trouble, you will find some differences or some change in the foot and the leg also. So this will be decided. The pathology around this area is very important. So AP view. Now this is the joint line and all these things that you have to keep in mind, that how much to use, how much not to use, how much has to be there or around. This is the area where the cruciate ligaments attachment is there. If there is any fracture or anything, then it is quite possible that the cruciate ligaments are anterior cruciate or posterior cruciate ligament is damaged. Now, this is the lateral view. Why lateral view is important? Lateral view is important for few things. One of the things is that in the lateral view, you will see the fat pad around. If there is any displacement of the fat pad, then this fat pad may be some blood or hemolysis or something is there that is there, or effusion is important. This is the patella again. Now the important point is these two lines that you have to keep in mind. Now this is the lateral lateral condyle and this is the medial condyle. As I already told you all that this the skyline view is more important for the uh, patella if there is any fracture or anything. Predominantly, skyline is done only for the patellar fracture or pathology, fracture most commonly. So, AP view taken from front to the back, best joint space narrowing, alignment, and the fracture. Now, regarding the alignment, I would like to tell you all one thing how to find out whether it is properly aligned or not. One thing is draw a straight line from the midline. If patella is in between, well and done. Or take a straight line uh, for 90-degree to from the femoral lateral epicondyle and come down. If you are crossing this tibia, the lateral end, well and good. It is very well aligned. If there is any fracture, you will find accordingly. And side view of the new is the best for diffusion and fluid, which I already skyline is sunrise. Weight bearing views is mainly for osteoarthritis, which we are seeing all chronic pain patients, definitely elderly. If someone after 50 years, definitely one should have a weight bearing view. Why weight bearing view is important? Because it is for the understanding whether there is any what is happening to the joint line and what is happening to the space. So A, B, C, and S. This is the most important thing. All of us has to look into the X-ray knee. One A for the alignment. Is the knee straight? Valgus deformity has to be seen. B is the for bone, for the cortex, whether there is any fracture or any bone lesion, or the osteophytes or bone spurs. Osteophytes, bone spurs, as I already told you, osteoarthritis is there. It can be there. In also important osteophytes is there if someone is having HO. If there is an HO, it will be not nearer to the bone. It may be a bit far away from the bone into the muscles. So these osteophytes are very important thing to be looked on. Cartilage, joint space have to be there. Thickness, narrowing cartilage, arthritis, and soft tissues definitely has a role to play. Distal femur, proximal tibia, fibula head, already these things I already told you. Joint space, medial, lateral, and patellofemoral. Why this is important? The medial joint space decreases most commonly in the osteoarthritis. Lateral in other type of arthritis, rheumatoid arthritis, and patellofemoral joint space is important if there is any fusion or any blood around it. So the fractures are there. Look for the if there is any break or any displacement is there. Some and then also it is common for the tibial plateau fracture or the patella fracture. When I'm saying tibial plateau, there are two types of plateaus are there. This one is the one on the lateral plateau, and this is called the medial plateau. If there is a fracture around this, definitely mm, yeah, you have to be a bit cautious. Patellar fracture very common. It is visible here, and what type of fracture is there, how many parts are there, and all these things can be seen through. Skyline will be definitely needed. Osteoarthritis. Remember, osteoarthritis is a very common. Rather, it is an epidemic nowadays because as degenerative changes are there, as the aging population is increasing day by day, the number of osteoarthritis cases are increasing. So all of us has to master in reading X-ray science for the osteoarthritis definitely at all cost. And this is the common KL grading system that is there. Sorry, there is some problem. I will just get back. I was discussing about osteoarthritis and why it is important because chronic pain we have to see day in, day out in OPD. Most of the patients will come to you chronic pain, either low back pain or the knee pain. So if you have to master this art of reading X-ray knee and understand what is the joint space narrowing. The best way to understand anything is go through 100 normal X-ray. At the end of this presentation, I will share one slide in which it is marked what all things one can read or one can see in the X-ray. So if there is any bony cysts or not, and always remember it is the medial compartment which affects us. Vestus VMO is the first muscle to get involved in osteoarthritis of the knee. Another thing is grade one will be uh, grade one, some osteophytes will be there. Grade two, there will be decrease in joint space, and grade three will be worsening, and grade four will need mostly TKR. So, and also why important? What is the importance of X-ray knee in osteoarthritis is on the basis of X-ray only all your treatment plan and therapy will be dependent. When exercises or therapy will be helpful, when medication and exercises will be helpful, when physical modalities, exercises, and medicine will be important, and how long medication has to be given. And then another important thing is grade two, grade three, and grade four as well. The importance of the X-ray is in deciding about your orthosis, what type of knee support you want to give. You want to give a knee support, you want to give a kneecap, or whatever you are going to plan or prescribe. Everything will depend on the X-ray as well as the clinical condition of the patient. Even if grade four you are giving prescribing a kneecap, it won't be of much benefit. In grade one or grade two, if grade one, if you are prescribing the knee support, it won't be of much benefit to the patient. Will rather it will be cumbersome and patient may not be lost to follow. So the X-ray has importance in deciding the treatment plan only for medication, bone strengthening, or exercises, physical modalities, and the orthosis which you are going to prescribe. So always remember, master this art, this reading of the X-ray knee. That's why it is very, very, very important for us. So, this is mainly for the bone. What about the other tissues, ligament injuries? There are a lot of indirect signs which you have to read, whether there is any avulsion fracture or if there is any joint effusion. Avulsion fracture is this one. You will find there at the plateau rind, or if there is tibial spine. If this spine, as I told you, this is a uh, cruciate ligaments, anterior and the posterior one, joints here. If there is a fracture, then it is quite possible there is a ACL tear. So these are the indirect things that you have to look in the X-ray. So the ligament injury also can be suspected or can be a part of your differential diagnosis, help you evaluate if you see a tibial spine avulsion. And of course, the joint effusion is there. Infection is there, then or bone destruction will be there, septic arthritis, osteomyelitis, everything can be there. If joint space widening is there, then arthritis chances are there. Then tumors, as you sclerotic bone, then something will be there, lesion will be there. So, and the important thing about these lesions are these margins are very irregular. It is like a bunch. So you have to look into all these things, and then if there is tumor, whether any biopsy is needed or MRI is needed or any further evaluation is needed, accordingly it can be decided. So another is what are the soft tissue signs in knee X-ray? Only everyone thinks that X-ray knee is means bone, bone, bone. No, there are a lot of soft tissue signs which can be seen in the X-ray, and accordingly we can plan it. Mainly it is the swelling or the fat pad the displacement will be there. and the fusion signs. For that, for these swellings, the best view is the lateral view. So if you are seeing through the lateral view, definitely all other views are important. But for soft tissue sign, lateral view becomes very, very important. And I will discuss how the soft tissue swelling will be there. There will be increase in soft tissue shadow. Can you see this? This is the fat pad, which is a normal thing, but there is some darkness is there compared to the fat pad will be there. That is a sign. Can be a blood, and there will be diffuse haziness around the joint. There will be bit of thickness. So you have to look into all these things. This is the alignment is changed, and this point, if fusion is there, soft tissue swelling is around this point is there. That has to be taken care of. See, around the lateral tibial plateau side. This is the lateral tibial? Because the fibula is around. So this plateau soft tissue is there. So what can be the cause? Trauma, infection, inflammation, everything is accountable for it. Fat pad displacement, is it whenever there is joint effusion, it pushes the fat pad out of the position. What is the normal fat pad position? This is the fat pad position, and it will be bit shifted. This is the area where if there is effusion, this will be there. If in this area the density is changed, it can be because of some fluid, synovial fluid, or it can be also because of some blood. Synovial fluid is the most common thing which you will see even in rheumatoid arthritis to osteoarthritis, everywhere you will see it. So keep eye on this area. This is the very, very, very important area to decide about what is the fat pad condition. And if there is any fat pad change or fat pad sign, that is also called mainly in the X-ray, if there is some diffusion around, some elevation, bulging. So for that to realize whether it is a fat pad sign, you have to see at least 100 normal X-ray knee. Remember, every time you see an X-ray knee, always see whatever I am teaching today. Every line becomes important. So if you have an idea where how the fat pad looks, then only you will realize. Eye sees what mind knows. So bulging will be there, elevated will be there, some fluid will is around the suprapatellar pouch. So joint fusion, accumulation around the knee joint will be there, and this seen in lateral view, as I already told you. Signs of effusion, suprapatellar, there is the displacement. If distension is there, then fat pad displacement is there, and soft tissues density is increased. That is again a sign of effusion. Whenever you are seeing any effusion or any bulge. Now, important point is, do we need to see effusion in everyone? For example, if someone with osteoarthritis knee comes with effusion, which you can clinically see. Yes, best is that X-ray to see, and you can compare with the normal X-ray. And always get an X-ray in osteoarthritis knee, both knee, so that you can compare accordingly. So if you can compare accordingly, you will realize, okay, this is the difference. Then only if there is mild diffusion, which cannot be palpated, you will be able to see in the X-ray. So always comparing with the other side and the normal side definitely helps, especially the for the effusion, it is the lateral view. So most important summary to realize is to look for the alignment, bone, space, soft tissue is there or not. But always remember, soft tissue is very, very crucial for you to realize. And X-ray knee is more than bone. So this is a osteophyte. Okay, many people of us are confused. This is not at all osteophyte. This is just a fibula, which is a sesamoid bone. Nothing much. It is a normal phenomenon. Find in many, find not found in many. So at many times people get confused. This is osteophyte. This may be positive. No, 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 not at all. So the last slide for all of you, just go through it. If you wish to take a screenshot, please take this screenshot because this screenshot will help you remember the most important things. So the fibula always, femur, remember one third should be visible, lower one third should be visible, and the medial condyle of the femur is there, epicondyle is there, Lateral condyle is the joint space, lateral joint space, medial joint space. This is the joint space which will be lost in the osteoarthritis first. Then the fibular head is important, and along with the fibular head, always look around the neck. If patient has a pain in the leg or weakness in the leg or the signs of foot drop, definitely at some point what happens, we do tend to miss with the gait that patient because of the osteoarthritis grade 4 has bowing of leg, and because of that he's walking like that. So always look into these things. So many things to look into the lateral view. So that's all from my side. If there is any question, do let me know. Okay, any question from anyone? So these are the small things which all of us has to remember. Yeah, I will stop the screen sharing. Okay, there is one question. Class on MRI knee. Okay, okay, Dr. Soumya, noted. Class on MRI knee. Okay, HO already was suggested last year. MRI knee. Okay, for MRI knee, we need to understand the anatomy of knee properly. Then only MRI knee will be easier to understand. Okay, anyway, one day I will take kindly do other joints X-ray too. Okay, okay, all other joints will do. Definitely, thanks for ideas. Uh, Anything else? Noted MRI knee, other joints. Okay, what we can do is patella pathology. Okay, okay, sideline view for patella. Okay, uh, just like last month. Okay, okay. This fat pad thing is the fat pad is a normal in everyone. If you suprapatellar fat pad is the most common pathology or the site where you will get pathology. If there is any abnormal fluid deposition or abnormal uh, uh, and abnormal, uh, if there is any abnormal collection around the bone and in between the fat pad is the first to get displaced. Always remember this. And if fat pad gets displaced, something will go and occupy the space there, and that is the pathology. So what can be pathology? Again, this pathology will depend on the history and the further clinical examination, and as well as the requirement. Then your differential diagnosis, what can be the differential diagnosis? Then accordingly, you have to decide further evaluation by the ultrasound, MSK ultrasound, or MRI. It depends on the clinical evaluation exam. Only by going through the X-ray, we cannot predict anything. X-ray is just a help in guiding us to move in a right direction. True AP and true lateral criteria. There is nothing called true AP and true lateral criteria. Okay, it is important thing, but for practical purpose, when you are sitting in OPD, getting a true AP view is very tough. Okay, and as I explained in my first slide, AP view, true AP will be something when patella is in the midline, and accordingly you can check and the lateral femoral condyle and the end of the tibia. should be in a straight line. So these things can be done, but it is not always possible to take a true picture or something like that. And true lateral view, again, it is how your beam is focused and all these things. So if there someone is coming with a pathology, perfect bone won't be there. Okay. So related pathologies regarding the fat pad is mostly the blood or the synovial fluid collection, or some fracture or some bone will be there. That can be osteophytes is a common thing that will displace it. So it is quite possible. HO features can also be there in fat pad displacement will be there. So once you start reading the mm, so look around it, and whenever you are seeing the lateral view, always look into the joint space, patella, fibula, and the condyles. Definitely, and all these things, and it is generally there is knee should be flexed at around 20 degree when you are taking the X-ray. And AP view again, as I told you, AP view can be supine lying or it can be straight line. Okay. Anything else? You know, because if there is any pathology, getting a true view is bit difficult. True AP and true knee, lateral knee, you will get only when it is a normal. So if you want a true picture of true AP and lateral view, my first slide was for that. Okay. So all of you can hear some announcement going on in the background. Okay. Sure. Anything else to discuss? Okay. Okay. If there is any other question or anything anyone want to discuss, or you can discuss in the Rehab Adda WhatsApp group, or if you wish to join, you can join that and share with your friends. And we will be most probably sharing within a day or two this video, presentation video. Okay. Okay. Thank you. So, shall we, Steffi, madam, shall we call off
Yes.
and
Yes, sir. We can end the session.
end this? Sure. Thank you.
Thank you, sir.